Again, that's my email and my Twitter thing. In the previous talk, nobody tweeted anything. I was very disappointed. Putting the patient first is something that I think anyone that is a clinician in the room will find important. If you're a patient, you would like that to be the case. And I would put forward that when patients come for our care, they have questions like, what is best for me? What is best for my family? And that what we all would want to be able to say is that our care is the answer to that question, that we can provide what is best for patients like Maria Luisa on this picture. One of the problems is that when we open the door of our clinics, the most likely patient to show up is very different from the patient that was imagined when chapters of the textbooks of medicine were written. This is the epidemiology that we are facing, an epidemiology of multi-comorbidity, common at old age to the right of the slide, but also common in middle age, where the average patient is no longer the average person is no longer a healthy person, but rather a patient, and a patient that is likely to present with one or more chronic conditions. This means that our labels, like the chapters in a textbook, or the specialties in internal medicine, or the buildings sometimes set up in our hospitals and clinics for each of the organs or diseases, are no longer as helpful as they used to be to describe those patients. If you look at the first row, a patient with diabetes, it seems arbitrary to describe that as a patient with diabetes when 61% also have hypertension and 23% have pain. Why pick them up from diabetes when we can pick them up from hypertension or other conditions? So this becomes increasingly arbitrary. And it's not trivial. We have to take into account that as patients accumulate multiple morbidities on the x-axis, their risk for adverse consequences changes. The risk of heart disease in somebody with diabetes is lower than somebody who has diabetes and hypertension and dyslipidemia. Also, on the y-axis, the responsiveness of patients to treatment differs as the treatments compound each other, interact with each other. So a patient with depression and diabetes, that you only treat the diabetes, you may not get as much response to the treatment than if you treat the patient's diabetes and depression at the same time. And in the third axis, in the z-axis, you have patients' vulnerability to side effects. So imagine again a patient with diabetes with neuropathy, unable to perceive his feet without looking at them, who every time he closes his eyes feels unstable, takes gabapentin to try to manage the pain from that neuropathy, and the dose has been increased to the point now that he has some degree of dizziness, and his doctor just read the SPRINT trial that says that your best blood pressure control is when your blood pressure is undetectable, and so when the guy stands up, he gets dizzy. So you can see that the combination of comorbidities, treatments for the comorbidities, renders the patient vulnerable to falls. So comorbidities and multimorbidity cannot be ignored for adequate treatment. Going to the guidelines, the fact that they're all written disease by disease makes it hard. A very thoughtful clinician that wants to adhere to each of the guidelines may find themselves putting the patients at risk. And this study indicated that while drug interactions are rare, mostly limited to kidney problems, these drug-drug interactions are more common, perhaps affecting 1 in 5 possible interactions among common combinations of conditions. You might argue that a thoughtful clinician will not make the mistake of applying the guidelines blindly, except that in different places, guidelines have been linked now with quality measures that are either publicly reported or connected with the income of the clinician in pay-for-performance schemes, limiting de facto the ability of the clinician to use judgment by virtue of these either carrots or sticks that are trying to modify the clinician's behavior. So the result of having evidence-based guidelines and care pathways and quality measures and specialist care, disease-focused and context-blind, is that in a patient with multiple chronic conditions, we're going to be putting together increasingly complex regimens. These regimens will stay increasingly complex as there is no one in the healthcare system with the job of prioritizing, that is, not only starting but also stopping so-called evidence-based or indicated interventions in patients in which the care is just excessive, or coordinate that care. And so what ends up happening is we have overwhelmed patients and overwhelmed families trying to make this all happen. When I talk about becoming overwhelmed, I'm suggesting that there is work. And one aspect of this that has been poorly recognized, in fact, I will challenge you to look for the chapter on any book on medicine on the work of the patient, is in fact the work of the patient. I think this is because for most of medicine, the patient would come to a hospital, lay in bed, and if you want to see who is doing the work, you will look around the bed to the nurses and doctors running around and doing procedures and managing treatments. But as patients have become chronic, all of that work now happens in the kitchen, in the bathroom, in the dining table, at work. And in those places, the main person doing the work is the patient and the patient's caregivers and family. So what is the work of patients? This is a extrapolation from sociology theories of work that I think are helpful because it's just simple 4 ways, but it makes us reflect on what patients have to do to make the work happen. They have to make sense of what the work is. Why am I doing this, and what is the purpose of this? This is why patients Google stuff. This is why they look at the package inserts of the medicines that they're being prescribed, sometimes to find out that the medicine has a side effect that seems very similar to the reason why the medicine was prescribed. And then we have those questions that come to us. Patients also have to organize the work and enroll others to help them achieve that work. On the graph on the top right, you see the patient in light blue shirt. That patient, it was Sunday afternoon, was watching TV, and his wife, to his left, his wife calls him to the living room to set up the pill box for the rest of the week. She does this every Sunday afternoon, often when he's watching some football game on TV, which he likes to watch. So he has to stop watching the game to come to the living room to set up the pill box for the week. And it is her organizational skills that keeps him treated. And you may notice that on her left wrist, she has a medical alert bracelet. She's also a patient. So if she were to go to hospital, for instance, be admitted to a hospital, he'll be on his own. Do you think that he will set up his pill box, or will he be taking the pills from each of the individual containers? And if he takes the pills from each of the individual containers, will he keep them all together? Will he be able to do this properly? So it looks like the work of adhering to therapy is social, and it requires, in this case, the family to be involved. He needs to keep her involved in that work. Now, he doesn't look particularly sick, does he? I mean, this is the problem with chronic disease, that patients do not seem to be suffering. In fact, they work very hard to look that way. I mean, if you look carefully at him, he may look a little lazy, but doesn't look sick. And so he needs to keep his wife engaged in his care. Somehow he needs to do some work to keep her in love of him, and that might take a lot of work for him to do. Then there is the work of going to the appointments and going to the visits and taking the pills. And then finally, the work of reflecting and monitoring and deciding that the work that was done today was worth doing because we'll have to do it again tomorrow. And this is also work that is very hard if the conditions you're treating are all asymptomatic. So when people don't do this work, what we do is we label them. We call them non-compliant. We don't label their situation, we label them. We think that they have a character flaw, that there's something wrong with them, that they are now non-compliant. So when Maria Luisa is reported to another clinician, she says, oh, I have an 82-year-old woman who is non-compliant. She is non-compliant, not her situation. She is non-compliant. So how did somebody end up not being able to do all the work that they need to do to be a good patient? Well, that brings us to understanding what is the capacity that people have to do that work. And you'll see the elements that provide people with capacity. You see things that perhaps are familiar to you. For instance, health literacy. But there are others like resilience or bandwidth that may be new. Bandwidth is particularly interesting, and that is the notion that when you're very worried, your ability to think clearly is impaired. And for people who have lack of time, lack of money, lack of friends, lack of health, and then they have an urgency that requires all of those resources to be mobilized, the worry about getting some of those might actually make them behave poorly. And so some people that have those limitations will make weird decisions about their care that are difficult to explain. And so that's the limited bandwidth. Poor health, if you can't, if you have a bad knee and you have to go from point A to point B, it may take you longer to go from point A to point B because of your knee, and so you may need to have physical rehabilitation to do that. But without it, if you take it too long, that means that in the given day you get to do fewer things. Mental health is another problem. Somebody has described depression as having to walk through molasses through the whole day. Again, it will take you too long to get some things done. Limited financial health is another problem. Someone has said that if you're poor, it takes too much time. Because you can't, money cannot buy you love, but it certainly can buy you help and assistance in getting things done. Social is another important one that it has two facets. One is the ability to ask for help, which some people lack the ability to graciously ask for help. But the second one is the nature of the social network around you that you can tap into to get the help that you need. And there are some interesting studies that suggest that most people with chronic conditions get most help from their weak ties, from the people that are in their social networks but are not linked to them directly, for, say, family. Some people get more help from the neighbor 2 doors down that agrees to take care of the dog while they go to a medical appointment. So all these things contribute to capacity, and people that lack some of these things will have limited capacity to face the work. So as we are thinking about translating evidence into practice, we need to think about what is the context of our patient, how much work can they take on that is worth doing, and what capacity can they mobilize to do this. So if a patient struggles to implement the treatment, they're not non-compliant. They're in a situation in which we may have introduced an imbalance between workload and capacity. And I would put forward that as clinicians, we do much better with syndromes than we are with labels of character. So instead of calling her non-compliant by saying that she has an imbalance of workload and capacity, we now have immediately a differential diagnosis that comes to our mind. Did we ask for too much? Did we increase the workload too much? Or maybe life increased the workload too much and she cannot cope anymore? Or do we need to boost her capacity so she can cope better? So what this brings to the fore is that in determining the net value of intervening on a particular patient, we must consider something that I think most of us have ignored for the most part, which is what is the burden of treatment that our recommendation will cause on patients. When people are making recommendations on the guideline, I would put forward that in general, this means that we must avoid making strong recommendations. These strong recommendations, another way of thinking about them is things you must do regardless of who the patient is, regardless of what the patient's circumstances are. If somebody comes in with to the emergency room with chest pain and you're going to put some aspirin under their tongue, you may not find out who they are, but you're doing good care. So maybe that's a good place for a strong recommendation. But making a strong recommendation in patients who are multimorbid, who have diabetes, hypertension, and other chronic, that's actually going to be much harder because we do not know how that additional piece of intervention will fall in the context of all the other things that the patients are doing. And they may actually cause, in that particular patient, net harm. So in those cases, I would think that in patients with multimorbidity, what we should prefer, our default, is to make conditional recommendations, conditional in part to the context of the patient, context of their biology, as in the comorbidities that we've been talking about, but also conditional on their biography, the complications of their life, and of the pursuit of their hopes and dreams. And one approach has been to involve patients in guidelines, and Walid mentioned a little bit of this about involving patient preferences, but it's not just preferences, but also perspective about this particular work that matters. And on one day in Berlin, we were some group of friends talking about the possibility of involving patient in guidelines. And one of those people in that room decided to go on and do something that we were just suggesting as an interesting exercise. And the interesting exercise was, instead of having a room full of experts with a token patient providing some insight that the patient may have, all using grade to make a recommendation, what if we had a room full of patients trained in using grade with a token clinician in the room? Would they give the same recommendations as the clinicians? Well, turns out they did the experiment, and they did it in rheumatoid arthritis. And they put together 10 patients. They trained them for 8 hours on grade. They had a physician in the room, and they had 2 grade facilitators in the room that usually do this job when this organization writes guidelines with a room full of clinicians. And they had 18 questions, 16 of which created a recommendation. And of the 16 recommendations, there were 2 in which there was a disagreement with the classic recommendations provided by a group of clinicians and the recommendations provided by the patient group. This is one of them. In patients with established rheumatoid arthritis with low disease activity, we recommend continuing with traditional disease-modifying therapy. The physicians felt that this should be a strong recommendation. In other words, everyone, regardless of their situation, should be continuing on this drug. And the patients thought that it should be conditional. And in the second example, in patients with established RA and low disease activity who are currently on methotrexate and an anti-TNF-alpha, we recommend continuing with the TNF-alpha inhibitor. Again, the physicians thought it was a strong recommendation. Everybody must do it. The patients turned this into a conditional recommendation. So in both situations, the direction of the patient's recommendation was to actually weaken the recommendation to create a little more space for discretion and accounting for conditions that are specific to the patient. In fact, if a summary or a way of thinking about this is that while guidelines are writing recommendations for people like Maria Luisa, the task of the clinicians as they face Maria Luisa is to take care of Maria Luisa, not of people like Maria Luisa. And so guidelines and those in charge of translating guidelines into practice must leave enough room for thoughtful clinicians and engaged patients to work together to figure out what the difference should be between the recommended course of action and the direct action. One approach is to engage patients in shared decision-making, and I'll discuss a little bit more in my talk on Saturday at the conference. But to give you an example, a common decision or common conclusion that people arrive at is that they would like to prevent coronary events using statins, particularly, for instance, in people with diabetes or with other risk factors. So here's a tool, the Statin Choice Decision Aid, and here's a calculation for a 55-year-old man with no risk factors beyond their age and gender, normal blood pressure, normal cholesterol profile, no blood pressure, no diabetes. And so in this man, what we would do is we show them in the room this, and then we show the panel on the left and say, Mr. Jones, you're in a room with 100 people just like you. If we close the door, open the door 10 years later, and we count, you will see there are 92 people in green that would not have had a heart attack in that period, and 8 people in orange that would have had a heart attack in the 10-year period. I do not know if you're one of the green ones or one of the orange ones. Now, if we were to give a statin, a pill to take every day, to each one of those 100 people just like you, close the door, they take a pill every day for 10 years, open the door 10 years later, and we count, the 92 people that were not destined to have a heart attack would have taken the pill every day, no benefit. Of the 8 people that were destined to have a heart attack, 6 people would still get the heart attack despite taking the pill, and 2 would avoid the heart attack because they took the statin. Again, I do not know if you're one of the green ones, one of the blue ones, or one of the orange ones. Now, if all of you were Mr. Jones, how many of you will be interested in taking a statin every day if this was applicable to you? I don't have a problem with my vision, and I see only one hand in the back. What's interesting, because of course the guidelines recommend that the current guidelines in the United States recommend that if your risk is more than 7.5%, you should be on a statin. And so, as you can see, the majority of you are non-compliant with the guidelines. The U.S. Preventive Services Task Force came up with guidelines more recently in which they made the 7.5 to 10% band conditional. and then the more than 10% that recommended, which of course makes no sense, because I don't think that many of you would have actually made a different decision if I had shown you a benefit of 2 out of 8 or a benefit of 2 out of 10, which is what would have happened there. But anyway, I think bringing these tools of shared decision-making to guideline deliberations may be helpful in avoiding these problems. If you were to have followed the guideline directly, perhaps you would have chosen not to engage the patient in shared decision-making, and you said, you know, Mr. Jones, just take the medicine, or in the case of Mrs. Jones, just take the medicine. And Iona Heath, a general internist from the UK, told a story, a very moving story, but it made a lot of sense, where a GP in the UK spent a lot of time explaining to an elderly woman about the need for her to start statins. And after a long silence, she looked at him and said, "But Jack is dead, and the boys are gone." You know, indicating that for her, the idea that taking a preventive intervention was not making much sense. In fact, one could argue that evidence-based care is the work of making care that actually makes sense, that makes intellectual sense based on evidence, that makes emotional sense, and makes practical sense, that it can be implemented given the complexity of life that people face. It's care that makes sense to the patient. And hopefully, as people like Maria Luisa come to see us and face these evidence-based clinicians we all want to be, and ask us what is best for me, what is best for my family, the answer that we can offer her is that the best care for you is the best care that we are able to offer her. Thank you very much for your attention.